Good morning, Senior Planet. This morning, we're going to talk about robotic surgery and the use of AI in those robots, mostly discussing how it's used in hospitals today and a little bit about how those might evolve in the future. So we're going to discuss and have some questions and answers. I've got a few slides to show you and a couple of videos to show you. So let's get started. So first, to introduce myself, my name is Roger Smith. I'm a computer scientist who works on robotic technology for the devices. I am not a surgeon, so we're not giving any medical advice here or telling you what you should or shouldn't do. That's your doctor's job. Don't trust me to do that. We're going to talk about the machines and what they're capable of. I worked in this field for 10 years before I became a consultant to hospitals and robotic surgery device companies. So in the field of surgery, people generally categorize it as falling into one of four dimensions or four generations of surgery. The first one is traditional open surgery, which has literally been happening for centuries, but in the sense that we mean it today, which is saving lives and providing science-based care, it really started in the 1800s. And open surgery is when you make an incision that's large enough to insert instruments or your big fat human hands so that you can remove an appendix or a piece of bowel, or you drill a hole in the head to try and relieve pressure. All the traditional things that you usually see in movies and that you're familiar with from your childhood. The second type is minimally invasive or laparoscopic surgery. And that really started to take off in the 1980s. In the 80s, they discovered that they could make small incisions, maybe a quarter of an inch, and insert their instruments on these long chopstick-like extensions so that the instrument that's inside your belly is smaller than the fingernail on your little finger, and the incision is about big enough for your little pinky to slide in or less instead of your whole hand. And the advantage of that is that you cut less tissue, so therefore you have less blood loss, you cut fewer nerve endings, you cut less muscle tissue, and you create a smaller opening for infectious things to get inside the body. And so it is safer and less intrusive in a lot of ways, but it is really difficult to master. There are a lot of tricky things that go along with this technique that challenge people to learn it over a year or more. The third generation started around 2000, and it's called robotic assisted because the robots help the human do the surgery. They don't usually do the surgery in place of the human. And in this case, in the most widely used forms, the robot grabs a hold of the backside of those instruments that have always been used in minimally invasive surgery, and they move those instruments more precisely and in smaller steps and allow you to have much more control and finesse. And the robotic arms move only when a human's hands move and give the command for the robot to follow in exactly the same pattern. Now, people are speculating that the fourth generation is going to be something like information guided. And ideas like that have already started, but you may not see them in your hospital for five years or more. And by information guided, what they mean is loading all of the information about you, your medical history, the images that were taken of your body, and the surgeon's plan for this procedure into the computer that's controlling the robot, so that the robot itself knows as much about you, the patient, and the procedure as the human surgeon does. And when it understands that much information, then it can give advice to the human surgeon based on thousands of previous surgeries that it's aware of. It can give warnings if the surgeon is doing something that may not be considered safe. And it can make records of each procedure, learning to do it better. So those are four typical generations. Now, this presentation is only, the recorded part is about 20 minutes long. We can't discuss all of the robots that are in use in your hospital today, much less the dozens that are in the research and development phase in that amount of time. And besides, somebody getting introduced to this idea couldn't understand the dozens of different variations of robots. So we're going to talk about exactly two, and no more than that, just two. The most widely used surgical robot is the Da Vinci, which is created by Intuitive Surgical. There are over 1 million procedures done with that robot every year. So we've got to talk about it if we're going to explain this field. And then another one that's very relevant to people at Senior Planet, who are typically 65 and older, is the Stryker Mako robot, which is used for hip and knee surgery. So let's take those one at a time. The Da Vinci robot is the one that most people have heard of. And so if you know about robotic surgery to any degree, you probably know about this robot. And the robot is built in 3 pieces, as you might have noticed on the previous slide. The robotic arms that attach to the instruments that enter the human body are those big white industrial looking things at the back of this picture. They're attached to the instruments that are still very small. And the chopstick that enters your body is literally smaller than the chopstick you would use to eat Chinese food. And the instrument that's down inside that's cutting, grasping, or burning tissue is smaller than the fingernail on your little finger. That device is connected to a surgeon's console, which is kind of like a cockpit. The surgeon pulls up to it, and he or she looks into a visual block, which gives them a 3D high-definition picture of the inside of your body. So they can see the inside of your body almost better than if they had leaned over and looked at it directly. Using that image, and it's magnified as well, also magnified, they will use their hand controls to move the instruments inside the body. And there's a scalar effect there so that the surgeon might move their hands by several inches, but the instruments inside the body may only move by several millimeters or a centimeter. So the movement gets scaled down. That means that the surgeon's large movements, which are natural to us as humans, are actually producing small, very precise movements inside the body. One of the advantages. Now, in the live presentation to the audience, we're going to watch a video, 2 minutes long, of the description of the Da Vinci robot. For this recorded version, I'm going to put that link in the notes section, and you can pause here and go watch that video yourself, but we're not going to sit here and wait for it to play. All right, so we take a pause at that point and discuss with the live audience, and then we move on to the Mako robot, which is made by Stryker. And you can see that this robot, very different from the Da Vinci robot. It's used for hip and knee replacements. So its focus is on operating on bones. You don't use it to make the incision, to peel back the muscle and the skin so you can get to the bones. You only use it when you're working on the bones themselves. And the robotic part is that blue and white machine that has the surgical drape over the top of it. And if you look closely, you can see that the white arm that comes over the top is actually attached to the instrument. This instrument is a saw, a bone saw, that's used to cut away the bone that's going to make room for the implant that's going to go in its place. And you can see that the human's hand is also holding that bone saw and guiding it along. The Mako robot, before the surgery happens, was loaded with the plan that the surgeon intended to do on this patient. And so before you ever came to surgery, you went in for imaging and they bent your knee in exactly this same shape. They took images of it from all directions and built a 3D model of your bones. Then the surgeon sat down and decided how deep a hole to drill in your femur, what parts of the edges of the bone to cut away, and exactly what angles all of that work should be done at. That information gets loaded into the computer that controls the robot, and then the robot essentially knows what the intended actions of the surgeon are, what the surgeon's going to do once they get you in there for real. So when you come in for the surgery and they bend your leg in exactly that same position, which they're instruments that help get that exactly right, then as the surgeon goes to work, the robotic arm does two things. One, it guides the surgeon and makes sure that they cut the bone exactly where it was specified in the plan. Exactly the right angle, exactly the right amount of bone. And that robot arm won't allow the surgeon to make a mistake. The surgeon can't wobble. They can't sneeze and cut away the wrong piece of bone. They can only cut away the exact piece of bone that was specified in the plan. The same with drilling a hole. You can only drill a hole at the perfect angle and at the exact depth that was specified in the plan. Now, the second thing the robot will do is if the surgeon misses some of the bone. So let's say you're drilling a hole and you intended it to be 2 inches deep and you only drilled in 1 3/4 of an inch. The robot system, the computer of the robot system, will show the surgeon the 1/4 of an inch that they missed. It won't actually go and drill for the surgeon. It will just make them aware that the plan was to take away more bone. And if the surgeon still intends to do that, then he or she can go in and get that other piece of bone out of there. So you can see that in this case, the robot is more actively involved in the procedure. It's actually guiding the surgeon as much as the surgeon is guiding the robot. All right, so we also have a 2-minute video that explains the Mako robot in detail. And in the live presentation, we're going to watch that. And you can watch it if you click on the link in the notes. Now, most people are quite surprised at how many robots are in use in their hospital systems. If you go to a large hospital in a major city, you'll find not 116, not yet, you'll find about a dozen different robots being used in that hospital system. They're used primarily for abdominal and thoracic procedures or the hips and knees that you saw in these two presentations. But in the R&D phase, there are literally more than 100 companies working on instruments that they hope to bring into your hospital system. Essentially, every surgical procedure that is currently being done with an instrument that was developed in the last 10 years, 20 years, or even 100 years, these companies hope to improve the performance of that procedure using an instrument that's newer, an instrument that we're calling robots. And so here's a list of 116 companies that are hoping to bring robotic assistance and robotic improvements to surgeries that are happening on the heart and the skin, dental surgery, eye surgery, brain surgery, even hair implant surgery, and spinal column surgery. I filled this slide up and I just can't fit any more company names on there, but every year there are even more companies. So robotics in surgery isn't something that's living in a small niche of the hospital and you won't run into it. It's moving throughout the field of surgery, and you can probably expect it to be used in almost every surgery sometime in the next 10 years, maybe a little longer. So that's what we're talking about, the robots themselves. Now, in this year, everybody in every presentation and every conference has got to talk about AI. It seems to be a prerogative of any professional presentation. So artificial intelligence is about bringing better tools and better partners to the operating room. bringing knowledge to assist the surgeon in the same way that older systems just brought instruments and tools to improve their procedure. And there's a couple of things that are really easy to explain that show what AI might do in the preoperative phase, the intraoperative phase, and the postoperative phase. So preoperative is before you arrive at the operating room. They could feed your medical records and all of your current symptoms into the AI, and it will compare it to millions of other patients that have been through something similar and predict roughly how your surgery is going to go, or suggest the best ways to deal with you. They can also ask the AI to process all of the images that are taken of your body. It can find the tumors, the obstructions, the edges of bones, as we described before, or any anomalies that need to be taken care of. And once it understands those kind of things, it can make suggestions to the surgeon before the surgery and make suggestions during the surgery. And then AI can also live in simulations of the robotic surgery devices and the procedures. And surgeons will use those to learn the skills that they need to operate the robot better and better and better. But you can also use simulations to show the patient what they're about to go through. And so a patient can have a much deeper understanding of what's going to happen to them in surgery, which we hope takes away some of the anxiety and fear about the procedure. Then during the intraoperative phase, the AI could recommend the best path from entry to the obstacle or the problem or the organ that's going to be removed. It could also suggest which instruments are best for what's being done. It can provide guidelines, like we talked about with the saw, making sure that the saw only cuts bone that was intended to be cut. And it can provide warnings if the surgeon is going in a bad area where maybe there's a lot of blood vessels, major blood vessels behind the tissue wall. It can warn the surgeon that they might not want to cut in that direction. And then it can also do mundane jobs like materials tracking. During a surgery, needles and sponges and various items go into the body and they come out again. And it's a surgical tech's job currently to count all the things that go in and count all the things that come out and make sure that everything that went in comes back out. The AI can assist with that and double check on the surgical tech to make sure that everything did get out of the body. And then post-operatively, knowing everything about your medical records and your physical condition and being an active part of the surgery itself, the AI can predict the outcome that's about to happen to you. It can give you a very close guess of what your recovery is going to be like, um, how long it should take, how long you might be incapacitated, what your healing path may look like. And so you're not guessing, and you're not just being given average numbers. You could be given numbers that are very close to what you would experience. And then the AI can also use all of that data to teach itself to become better. Because when the AI that's software learns something unique or learns to perform its job better on your procedure, that's one data point that rolls back into the model and instantly makes every other robot using this AI better. And so that information about how to perform a procedure better doesn't have to be passed from one surgeon to a small group during a conference 9 months later. It can be passed to all of the robots the very next day if necessary. So those are some exciting changes for robotics. And they're the kind of thing that literally I write about in my future fiction surgical series. The Surgeon in the Mirror, Against a Viral Threat, and Savior of the War-Torn is a series of 3 books currently that deal with what robotic surgery will be like in the very near future. And the intention is not to be Star Trek kind of fiction. It's meant to be the kind of fiction that it becomes fact 5 years from now. So you can look those up if you want to delve into some of these ideas in more detail. And that's all we have for our presentation to Senior Planet. Thank you very much.